Hi,
morning.
Dr. Men. Good morning. Good afternoon. Happy World Perimenopause Day.
Happy. It's a weird thing to celebrate. It's
I know,
awesome.
but do it we will. And I was just about to formally introduce you as certainly one of our very favorites here on the Alloy platform and in the world of this conversation around perimenopause and menopause. You are also an OBGYN and an Alloy prescribing physician and Alloy's Director of Clinical Innovation and Education. Um, a perfect person to speak to on this day. I wanted to begin with a couple of questions. I had a whole bunch lined up.
Sure.
And then when I shared that we were going to have this live, a slew of questions came in from women. And I always love when that happens. And especially today, I thought, what better way to kind of put a stamp on this day than hear from women themselves? So I wanted to go through those questions with you. But I
Great.
wonder if you could start, we're going to get into like a lot of heavy questions and things that are disturbing for women going through the season or confusing or whatever it is. And I sort of wanted you to reframe this season for us all and I guess kind of help us shine a light on perimenopause, especially for women who may or may not realize they're there yet.
Yeah, I mean, I just think it's really important for women to be aware of the physiology of the perimenopause. It's a normal transition that everybody who is going from regular ovarian function and regular cycles to the menopause transition, and it can last up to 10 years. So the average age of menopause being 51. So the perimenopause can kick in 10 years prior, and understanding that normal menopause can range from 46 to about 56. So you could be in your late 30s and start to experience things like menstrual irregularities, mood changes, various symptoms that we can certainly get into. And while I think doctors are starting to become a bit more aware of menopause and how to manage it and hormone therapy, the perimenopause is the most complicated time, frankly, to manage in terms of recognizing symptoms, how to manage hormone therapy options, birth control pills. There's a lot of confusion, I think, even more so around perimenopause than menopause. So we'll hopefully clear up a lot of that confusion. And just to think of this as a season of change, right? We're in the fall season. It's a change, it's a shift, and it's a season of opportunity. So instead of being sad about perimenopause, being like glad because your body's telling you something, there's a change. Hey, I have to wake up and ask for help, do different things with my lifestyle and really kind of think about this as a window of opportunity, not some doom and gloom situation, because it's not.
Yeah, it's
Yeah.
not. I love that. And I so appreciate your amplifying that. I have often felt like perimenopause is just that. It's this window of opportunity that
Yeah.
opens, often with something that might be difficult, but it kind of allows us to home in on ourselves in a way that we probably hadn't to
Yeah.
that date. And so thinking about all the lifestyle stuff, which I'm sure you'll get into, and also any therapies that are hormone therapy or birth control, as you mentioned, that might be super helpful and just helping to like quiet down the symptoms. To that end, what is a myth that continues to hold women back during perimenopause? And how do you help them see that even as the science evolves, they deserve care and solutions right now?
I mean, the biggest common myth is that it can't be menopause if you are still getting a period or you have normal levels, right? So in this menopause care vacuum that I often allude to, women go and seek care from people who mean well. Doctors mean well. They're trying their best in this very difficult medical world we live in. And they often don't have enough time to help patients. And they're not well educated in menopause, much as perimenopause. So women ask for things like, I want a hormone panel, so they get blood work done, right? And it's certainly fine if you want to get blood work done, but the reality is in the perimenopause your hormones are up and down and all over the place, so they're just literally a snapshot in time. So many women come and say, I went to my doctor with symptoms of new onset of anxiety. I'm not sleeping as well. I've got some weight changes, maybe a little vaginal dryness, occasional heart palpitations. And they're told, well, your blood work is normal. You're only 42. You're
Right.
a decade before menopause. It can't possibly be that. And then that's when they get set down the road of being put on an antidepressant or just told, no, this is just stress. You're just getting older. This is not menopause. I think that's the number one like barrier, a really common myth, right? And the simple answer is you can have perimenopausal symptoms, the whole range of them, and there's lots of them,
Hmm.
and your labs can appear very, very normal, right?
Yeah.
So, it's a perimenopause, full stop, is a clinical diagnosis, meaning we listen to your symptoms, we listen to your menstrual history, like what's going on with your periods. We put it all together. We make sure we exclude any odd things like a new onset of like a thyroid disorder or
Right.
iron deficiency anemia if you're bleeding really heavily. And there's other things for us to look at, but you know, largely this is a clinical diagnosis.
Dr. Menn, before we get into questions, could you take us through sort of like head to toe what some of the symptoms might be, particularly those that women may be already experiencing, have no idea? And I'm not saying it's assuredly perimenopause, but I am saying that like it's a moment to get enlightened about what could be going
Yeah.
on.
So people always think of hot flashes, but hot flashes are sometimes present in perimenopause, sometimes they're not, and they can come and go. Because again, it's a transition time. Sometimes some months, some weeks, your estrogen and progesterone levels are normal in the normal ratios that would normally be in, and you feel okay. And then you might like go a couple months and be like, oh, I've been feeling warm lately, or I'm not sleeping well. But if you don't have hot flashes, but you are noticing things like, wow, I'm waking up in the middle of the night, I'm having a harder time falling asleep. I alluded to heart palpitations, very, very common. Heart palpitations without chest pain or shortness of breath. Of course, any heart symptoms you want to speak to your internist about, but if you're otherwise feeling okay, and it's like these new heart palpitations, this is one of the symptoms Oprah spoke about as being an under-recognized thing that she was dealing with for years, and it was really just perimenopause into menopause. Skin changes, dryness of the skin, not just vaginal dryness. People say skin, their ears feel dry, their skin feels dry, everything. New onset of anxiety, new mood changes. Now listen, depression and generalized anxiety are separate and real diagnoses, but if you have had stable anxiety and depression and you've been doing well on medications or however you manage it, and suddenly it's like out of the blue, it's getting worse, or you never had a diagnosis of depression or anxiety, and out of the blue, you have this new onset of that is extremely, extremely common.
Um,
And our first knee-jerk reaction is really to be like, okay, we've got a 40-something-year-old woman with this new sort of onset of anxiety and sleep issues. Maybe we should ask a few more questions to
mm,
see, is this hormonally related? Could we support her in other ways? Because the knee-jerk reaction of an antidepressant, well, can be helpful, may not be the full picture, the
right.
only answer, or even the correct answer.
Right.
Sometimes hormone therapy is the correct answer in that. So I think those are big ones that like we think about. But then the other things are also new onset of joint pain, muscle aches and pains, the weight, which we'll talk about, because the perimenopause transition is a time where the fluctuating estrogen levels, um, coupled with the lack of sleep, those
Hmm.
two things really do a number on us lowering our basal metabolic rate, right? So we may be eating and exercising the same as we always did, but we're starting to pack on pounds because our metabolic rate is lower. More fat is being directed around our belly. That fat is deeper around our organs, causes like inflammation, antagonizes things like insulin and glucose. And so there's a lot of factors that go into play. And I always remind patients, if you are suddenly not sleeping, that has so many downstream effects
Yeah.
on mood, ability to exercise, your weight, lots of things. So to me, like all of these things are little canaries in the coal mine where you need to be like, hey, something's different. We warn our daughters, right, around age 9, 10, that,
Yeah.
hey, this is what happens with your periods. Let us know if you're starting to feel this or that. We kind of explain to them skin changes, new onset of like say acne breakouts. They're feeling more moody. They feel crampy. They feel bloated. they start to have irregular spotting and bleeding with their first, 6 months to a year of their periods, we explain to them it's a transition. They even take classes like
Yeah.
at their middle schools. But the perimenopausal and menopausal woman doesn't get any of this proactive education, right?
Yeah.
They
Yeah.
they get it. They get prenatal classes before they give birth. They get the classes for their puberty. But this is why
And
we're
you're
doing
cut loose.
we're
Yeah.
doing we're doing classes for these ladies in perimenopause. And so don't be afraid of it. Be like, oh, okay, this is what's happening, and we have a lot of tools
Yeah,
to address it.
I just want to highlight also that this is something I will say in support groups a lot is to encourage women to write down what
Yes.
seems new or
Mhm.
unexpected,
Yep.
because when you go into your gynecologist's office, who is likely to be the first clinical clinician that you
Mhm.
have a conversation with about what's going on, you've got like 15 minutes and a pap smear and a breast exam, and things are moving really fast. And if you go in armed with that self
Yes.
data, it can hopefully open a conversation right then and there. Somebody mentioned memory issues, and I
Yep.
know like
Mhm.
that can also be a thing, brain fog,
Yes.
memory. Yeah.
Yeah. And it's complicated. It's due to the fluctuating changes in your hormones, particularly estrogen, and its impact on the brain, coupled with lack of sleep, drives it as well. Something reassuring to say: it does not mean you're getting early onset
Yeah.
Alzheimer's or dementia. And we know from research that the time period where women have the worst brain fog and kind of often feeling patients often report to me they feel like new onset of ADHD like symptoms. They're like, oh, maybe I'm ADHD and I was misdiagnosed, which many women might have been underdiagnosed through the years because it presents more atypically in women. But a lot of times, it's actually just the perimenopause
Yeah.
causing attention, some like short-term memory issues, brain fog, etc. Super, super common symptom. Um, Very scary for women, though.
Yeah,
Yeah.
very, very much. Okay, I want to start to turn to questions, and I am paying
Yep.
attention to questions that come in. I know that
Sure.
testosterone will be one that comes up a
Yep.
lot, so we'll get back to that in a
Yeah, we
moment.
will.
This first question, how do I know if what I'm feeling is perimenopause or just stress or aging? I just turned 40.
Well, it's probably all three because
Mhm.
certainly none of us can escape stress in our lives. But if a doctor tells you, well, this is just a more stressful time, I would beg to differ. Okay. You have, as a grown woman, you've probably experienced stress at every decade of your life for different reasons. And we can't just chalk up all of our symptoms to just, oh, well, the 40s,
Yeah,
it's stressful. That's a very dismissive thing to say to a woman. Now, we can recognize that stress impacts our body, our sleep, all these things. But I think how I would answer that is write down the constellation of symptoms. Again, it's a clinical diagnosis. So if you say, okay, new onset of anxiety, and then you also start to check some of the boxes of the other symptoms we spoke about, and then you look at your menstrual pattern, which we know is tricky if someone's on an IUD or birth control pill, so you don't necessarily know what's happening there. But if you can tell what's happening with your periods, you put those two things together, period changes and this constellation of the number of symptoms, and then your age, like
yeah,
35 and above, yeah, it's called
yeah.
perimenopause.
Yeah. This next question, I thought it sort of overlaps, but the last part of it, I really wanted you to be able to speak to. This woman asked, what's a sign I should see a doctor? I can't tell how bad I feel at any given time. I just manage the best I can.
All right, so you've already answered your own question. If you are managing the best you can and you feel bad, you don't have to wait until you are in a horrific state and really suffering and it's debilitating.
Yes.
But frankly, that is the message that women have been sent for, I don't know, thousands of years, right? To
Mhm.
toughen it up. It's your role to just push through it. We don't ask you to do that for really any other medical change or condition. So if it's something that is enough that making you ask that question, well, then I think it's time that you go and try to get help. And it doesn't mean that you automatically have to go on hormone therapy, but you should at least have a discussion of like, hey, I've got these symptoms. What are the tools that I can use? Yes, hormone therapy is one of those tools, but it also opens up a chance for a broader conversation about
Right.
why this is a window of opportunity to introduce lots of things and kind of really reassess where your health is.
Great. I want to actually to some questions that came in. Let's address testosterone for a
Yep.
moment,
Mhm.
and then I'll go on to the next.
Sure. So testosterone doesn't precipitously drop like it does, like estrogen levels and progesterone levels happen when we enter final, last menstrual period and you go into menopause. Testosterone levels slowly decline for both men and women with age. Some things that would make it happen, drop even more would be if you had your ovaries removed surgically. We know that their levels are even lower because your ovaries make a large proportion, although there's testosterone is made in other parts of your body. So the testosterone question comes up a lot in perimenopause because of this. Women are told by often clinicians who don't know anything about menopause that their estrogen level is normal and we can't give you any estrogen. You don't need hormone therapy until you're without a period. And so they still don't feel good. They have low libido. They're not interested in sex because of probably a lot of the symptoms we just talked about. When you're not sleeping, you don't feel great. Maybe you have vaginal dryness. You're certainly not going to want to desire sex then. And so they're told, okay, testosterone is your solution now. Now, testosterone, we have a global position statement and really good evidence-based guidelines that we can use testosterone very safely in low amounts that are appropriate for a woman to help with hypoactive sexual desire disorder, so low libido. Is there evidence that some women feel better in other avenues, other places? Yeah, maybe more energy. There's some suggestion that they feel, better sleep. Some women have said it actually helps with their hot flashes and night sweats. Some of those things may be true, but we don't have the full picture
Right.
that we can guarantee that. So what I tell women is know why you're asking for testosterone. If you're perimenopausal, please make sure you're addressing your symptoms. I can't tell you how many women who have come to us for care at Alloy have told me they're on testosterone pellets, which we generally don't recommend pellets. It's one option you can use, but we generally recommend using a low dose of a transdermal testosterone gel that's approved for men, but you use in a lower dose for women. And the primarily reason why you should be asking for that is for the libido. But if you have vaginal dryness and sex hurts, if
Mhm.
you are not sleeping well, if you are having some night sweats or hot flushes or all the other symptoms, testosterone is not the first line medication you go to. You should be evaluated for perimenopause and menopause treatment with hormone therapy. We can add in testosterone. A doctor can add that in down the road, or in conjunction. But we really, I see a knee jerk reaction, fear about estrogen,
Yeah.
fear about estrogen causing breast cancer, misunderstanding that we don't have to wait to your final menstrual period to use HRT. And so what happens instead is people think, oh, well, then testosterone is my ultimate solution now. It can be part of the puzzle. But once we get your estrogen, progesterone, vaginal estrogen, if we needed, under control, we implement good lifestyle stuff. If you still have persistent low desire, testosterone is a great thing to add in at that point.
Okay, thank
Yeah.
you so much for that. Somebody asked about having DCIS,
Mhm.
had surgery, is having trouble accessing menopause hormonal therapy. I don't want to get you stuck on a
Yeah.
big cancer discussion, and I do want to let people know that we are going to have a webinar and a support group to follow
Yeah.
on breast health and hormone care. So please do look out for that. But if there's anything you wanted to add in this moment,
Yeah. I mean,
you're
listen,
welcome.
DCIS is very commonly the age group we see it a lot in is women in their 40s. So, often we see women who are perimenopausal dealing with a new diagnosis of DCS. Some of these women were already on hormone therapy, being told to come off of it. I think my message to this patient is you really have to um, really be a squeaky wheel, and you really need to have individualized shared decision making with your medical oncologist, your breast surgeon, whoever's helping you manage your menopause. There are some patients who have DCIS who have had bilateral mastectomies, and they can consider going back on hormone therapy. There are some DCIS patients who have only had a lumpectomy, radiation, and they might be dealing with a lot of menopausal symptoms and are being told to be on estrogen blockers like tamoxifen, aromatase inhibitors, etc. That's where they really need expert help in either managing their menopause non-hormonally. They can always use vaginal estrogen, always safe for all these patients. Um, and sometimes, if they are really not tolerating those medications, they should have shared decision making about how they can adjust them, right? There's a medication called Duav, which I'm a huge fan of in the DCIS population, not approved for treatment, but it may be something interesting to use as hormone therapy option in the women who have had DCIS and lumpectomies. So talk to your doctor about Duav in the new Promise trial with DCIS, and
Great.
then we'll move on and we can do more in our
We'll move
webinar.
on and we'll save the rest for our webinar.
Yeah.
Somebody asked specifically about their own dosing. How do you know when to increase dosing? This question comes up a lot. So can you speak to that? This person
Yeah.
says she's 38 and she's started hormone therapy and it's made a huge difference in her life, but when does she crank it up?
Dosing is really individualized, and we really dose things based on your symptoms, how you're doing on them, and if you're having any side effects, right? So the trickiest thing about perimenopause is your ovaries are still working.
Yeah.
Perimenopause, by definition, means that you are still having some ovulatory cycles. Your ovaries are still sometimes producing estrogen. When it ovulates, your ovary, it'll produce progesterone. The months that you don't ovulate, you may have a lot of estrogen being produced and no progesterone, hence why women will get breast tenderness, bloating, an acne breakout, more moody, and then either they finally ovulate or they finally shed their lining and have an irregular period. So this is why dosing in perimenopause is tricky. Often we'll start with a low, steady dose of estrogen, and sometimes we have to go up or down based on your symptoms. That's why birth control pills take away the confusion of dosing because it shuts down what's happening with your ovaries, right? A lot of patients they're worried that they need to be on a certain dose to protect their health. And my message to you is we will never just arbitrarily raise your dose to make your estrogen levels somehow magically higher if you're feeling well on a lower dose. If you feel good on your dose, that's all the information you need to know. We are not targeting a particular level. The only time we do that is if you have true premature ovarian failure prior to the age of 40. And in that case, we actually need higher doses to adequately protect your bones, right? The other dosing issue that comes up is if you're having a lot of breakthrough bleeding or heavy bleeding, needs to be evaluated. And sometimes we have to increase the dose of the progesterone to offset the estrogen on protecting the lining. Again, these dosing questions make perimenopause sometimes more complicated. Again, why we're here at Alloy, because all of the physicians here are like true experts with decades of experience in managing hormone therapy. We didn't just learn it in a course recently. Like we've been doing it for a long time. So we know how to answer like these tricky questions.
Yeah, that's great.
Yeah.
Thank you for that. I also just want to piggyback anecdotally and say, as a regular woman going through this, who works, with all of you clinicians and has asked lots of questions, I myself have had to go up, have had to go down,
I
and
know.
right, Dr. Menn is my physician, and just knowing sort
You've
of
been a little
being.
tricky.
I've been a little tricky. I've been a
We've
little
had to
tricky.
manage you.
Yes, yes, and I think being unafraid about it and
Yeah.
recognizing that like it's fine tuning the machine. It's not like a one and done, and
Yeah.
that's okay. I have another question that came in here privately before I get back to our next section of questions,
Yeah.
which is on sex and intimacy. And this woman asks, says she has had a total hysterectomy and was put in surgical menopause. She's been on a 0.05 patch for perimenopausal symptoms have returned, her symptoms, excuse me, have returned severely. How often can the patch be adjusted? So this kind of
Oh yeah. Well,
goes
a couple
on.
of things. So it sounds like so it's hard to know if she had her ovaries removed or not. So very interesting. So it sounds like in this patient's case, she had both ovaries and her uterus removed if she was plunged immediately into menopause. But I'm just going to note, you can have your uterus removed for, say, fibroids or endometriosis, and they preserve your ovaries, and you're younger, say you're in your late 30s or early 40s. You are not menopausal until your ovaries stop producing estrogen. So sometimes perimenopausal women who have their ovaries, they don't have their uterus, Those women are tricky to manage because they're given estrogen alone. But a lot
Right.
of these women still have irregular ovulation and they could really benefit from progesterone. So just a little heads up there. It sounds like this woman had both ovaries and uterus removed, and a 0.05 patch is an average dose patch. We've got two patches above. Some people do better on oral, some people do better on a gel. So if you feel like not all of your symptoms are being met, number one, you can certainly adjust it. How often? As often as you need. You know, things change. Number two is, while we don't have to use a progestin or a progesterone to protect the lining of the uterus in women who have had their uterus removed, we can still use progesterone. It's not like progesterone only works on the uterus, right?
Right.
The reason why we use estrogen alone is because when it's simpler to, from the WHI data, the women who use conjugated equine estrogen alone had a lower risk of breast cancer, a lower risk of dying of breast cancer. So it appeared that estrogen alone is quote unquote the safest option in terms of that. That being said, many women could benefit from oral progesterone at night even if you don't have your uterus. So that's just another little tip.
Okay, terrific.
Yeah.
I just spotted one more question. Sorry, before I turn back to the
Mhm.
ones I got in. This is a great question because it also makes me think about birth control.
Yep.
How do you notice symptoms when you're on a hormonal IUD? She says, I feel like
Yeah.
I should be noticing something, but I'm really not noticing anything, and I'm almost 50.
Okay. Well, a couple of things. Number one, the IUDs do a beautiful job at giving you contraception, making the lining of your uterus really thin, so you really shouldn't have bleeding or cramping. I mean, sometimes some women have a little bit, but generally no. So that's great. Now, if you're the average age of menopause 51, you know, you may literally just not be menopausal yet. That's why you don't notice any symptoms. I've got
Right.
women who are 55 who are still having menstrual cycles. So remember, just at 51, it just may not have happened for you, right? Um, and so it's always a little trickier because you don't have the telltale sign of your period being changed, right? And you know, we can't accurately measure hormone levels when women have they're using contraceptives. Um, so I'd say if you're feeling good, otherwise, you don't necessarily have to start anything, but start to think about some of the less typical symptoms. You know, if you start to notice symptoms, the great thing about an IUD is we can add estrogen, low dose of estrogen, and we don't even have to add a progestin or a progesterone as long as that IUD is up to date. So,
Great. On to sex and intimacy.
mhm.
This person asks, why do I sometimes feel desire one day and zero interest the next? Is this hormonal or in my head?
Well, it could be both, but I think we have to remember that it is very normal to sometimes desire sex and sometimes not. You are not, as a body, as a woman, meant to just spontaneously want to have sex all the time. That's called spontaneous desire versus receptive desire. Receptive desire means if your partner initiates something or you initiate something for yourself, and then you're like, oh, that feels good, or oh, that's nice. Oh, now I'm interested. Now I want it. That's called receptive desire. And that's the norm for women, right? So, first of all, normalize that you're not always going to want to have sex. But
Right.
if it's something that's bothering you, you're like, I don't want it sometimes and it bothers me. Well, certainly that's something we should talk about and we should like look at the big picture. So, really quickly, biopsychosocial. So, there's biological things that are happening. If you're not sleeping, if you are having hot flashes or night sweats, if you have vaginal dryness or just decreased sensation, decreased lubrication, um, diminished orgasms. The loss of estrogen can profoundly impact the tissue, you know, in the genital area. And so if things just don't feel as good or they're a little uncomfortable, that's a really negative feedback on your brain. Your brain is going to say, I don't want something that kind of hurts or something that's just like, right? So that can decrease desire, right? Um, as can obviously the other symptoms of like lack of sleep, etc. Psychological things that are happening in terms of stress and anxiety in your life, also relationship things that are happening, right? So there's a lot of pictures. It's not always, you know, something wrong with you.
Right.
The lowering of testosterone levels with age can certainly impact your desire. You know, women in general who feel better, their quality of life is improved when they're on hormone therapy to treat symptoms and they get their vaginal health back in order with vaginal estrogen, a lot of times that goes a long way to feeling your best so that your receptive desire can kick in and like, be there. My favorite book for this, which I think is Kelly Kasperson's You Are Not Broken. So if you are feeling like, oh, is something wrong with me? Am I broken? Like, check that book out. And yeah, make sure you're addressing all of your perimenopausal symptoms.
Awesome. Um, Mismatched libido. My partner's libido is going up, mine is going down. How can couples navigate that?
Yeah, well, well, I would again recommend the book You're
The
Not
book.
Broken. Number one, that is important. Also, recognizing communication is key. Communication is sexy, right?
Yes.
And so you should kind of speak to your partner about why you are not interested, and sometimes letting them know. I think it's pretty sexy, actually. I've heard from men saying like, "Wow, it's sexy when my partner wants to say like, hey, can we work through this? And
Yes.
hey buddy, I gotta give you a heads up, like I don't sleep well at night and it's a little drier, and hey, you get easy access to erectile dysfunction medication. So just to keep all these ladies like in the know, like 50% of men by the age of around 50 will have some form of erectile dysfunction. It's very easy for them to get medications like sildenafil, Viagra, right? And so, we have to ask, like, what are the doctors doing for the female partners of those penis owners, right? And so, really, this is when you have to be like, all right, it's time for me to take care of myself and explore why I'm not interested in it, right? And to know we do have good solutions for sexual health. I mean, obviously, treating your menopausal symptoms, definitely vaginal estrogen. We do have something called topical sildenafil, which has a growing body of research that low dose topical, same medication that's in Viagra, can be applied onto the vulva, the clitoris, about 30 minutes, 15, 30 minutes prior to intimacy, increases blood flow to the area, so increases arousal, increases lubrication and pleasure. So how does that help desire? Well, if your acts of sex are more pleasurable, the next time you're going to remember that, and your
Right.
brain, which is your biggest sex organ, is going to desire it. But I just think these changes, just like perimenopause, they're wake up calls to investigate. And what I have found in my practice and seeing thousands of patients on Alloy is that women can have better sex lives than they ever have had in their past, even after menopause, because there's so many freeing things about menopause. You stand up, you speak up for what you want, you're more comfortable in your own skin, um, and you know your body better, and you don't have to worry about getting pregnant. So there's a
Yes.
lot of hope.
It's a
There's
lot
a
of
lot of
freedom
hope.
in that. Yes,
Yeah.
yes, yes. Um, this next question, I she says, I feel like I'm suddenly having vaginal dryness or urinary issues.
Mhm.
No one warned me about this. And then she actually got back to me later and said I'm 42 years old.
You need vaginal estrogen.
Yeah.
Full
Yeah.
stop.
Yeah.
Vaginal estrogen, Dr. Rachel Rubin loves to say vaginal estrogen is like female Viagra. Why? Because it increases blood flow to the clitoris and vulva. It improves the tissue quality. And GSM, genitourinary syndrome of menopause, includes urinary urgency, frequency, feeling like you have a UTI, getting a UTI. And these symptoms for some women start in perimenopause. For other women, it starts later after a number of years of estrogen loss into the menopause. Um, so it varies in terms of when it presents, but once it presents, it's chronic and it's progressive unless you do something about it. A moisturizer can help with symptoms. A lubricant can help with intimacy and decreasing friction. Neither address the root problem,
Right.
which is the loss of estrogen, vaginal estrogen, for the win and for life.
Awesome. Wait. Um, this lady says, I'm definitely gaining weight in my midsection no matter what I do. I'm 38. I'll just tell you the second question that came in now. Is it even possible to lose weight during perimenopause, or should I just stop fighting it?
No, you should not stop fighting it, but we have to like deal with it in a smarter way, right? And so we should get away from the number on the scale and thinking about what is our health. Again, this is a wake up call. Your body is saying something's different. your body's changing. It is changing, right? And so you want to think about this idea of body recomposition, right? You are at risk right now of gaining fat around your belly and just gaining more fat in areas, right? Because of the metabolic changes of aging and the hormonal shift, right? So you have to focus on increasing your skeletal muscle, increasing muscle, improving your metabolism with excellent sleep, really excellent nutrition, and that can go a long way to helping you. Now, the reality is many women come into the perimenopause already with they've struggled with weight, with overweight, with obesity. Some women, it's new for them. They were always maintaining their weight. And so there isn't one magic approach. So this is where, depending on your BMI and your weight, sometimes a GLP-1 medication is important. And we help patients with that at Alloy. Getting your perimenopausal symptoms in check goes a long way. MHT is not a weight loss drug. I
Right.
cannot give you an estrogen, patch, and progesterone, and you cannot expect that you're going to lose 5 or 10 pounds in the next couple months.
Right.
But if you are having all sorts of symptoms and your quality of life is diminished, and we get that in order with your hormone therapy, you will are then able to do the pillars of lifestyle medicine that we know are necessary.
Yeah.
So I really encourage women to think about this as a holistic approach, right? Now is a great time to get a baseline bone density, to know what your cholesterol is, your blood lipids, to know what your BMI is, to do, although the BMI is not everything, to do a waist circumference and kind of just get some parameters. Dr. Von der Wright's new book, Unbreakable, is a great starting point to understand this and to give you a basic plan. I think that's one of my favorite new references out there if you're interested in this.
Okay, thank you for that. Um, Moving on to mood, mind, and emotions.
Mm.
This first question, I feel like a different person, and my husband has voiced that I seem really different. Honestly, he said he feels like he's walking on eggshells around me. I'm anxious, irritable, even ragey sometimes. I'm starting to get the picture that this is hormones. I'm 42 years old and I still get a period. You
Yep.
spoke about this earlier.
Yep. And so just last year was published in, I believe it was the Menopause Journal. It was called I'm feeling like NFLM, not feeling like
Like
myself.
myself.
And it was literally, researchers looked at, and it is like one of the most common complaints that women say. And they're often through the decades and years have been dismissed as like, oh, you're crazy, you're just stressed out, you're tired, you know. No. The loss of estrogen, the fluctuation of estrogen and progesterone impacts your brain full stop. Okay.
Yeah.
So it's not just lack of sleep or hot flashes, it's actual direct, impacts, on your brain, on your cognition, on your threshold for dealing with anxiety. All estrogen, progesterone impact neurotransmitters like serotonin, norepinephrine. If you're still getting your periods, it really depends on how we approach this, right? Now, of course, if you have signs of clinical depression or anxiety, sometimes we do bring in psychiatric medications like an anti-anxiety medications or an SSRI. But when it seems like it's clearly a new onset and otherwise you don't have depression, menopausal hormone therapy can be life changing. And yes, if you're still getting your period, yes, your ovaries are still making estrogen and they're still making progesterone. The trend is erratic, and the trend is erratic going to low. Not always low, sometimes high. Sometimes very high levels of estrogen make women feel very emotional, very edgy, right? Think about how you might have felt when you were a teenager, maybe, and you
Yeah.
were having all your PMS. You would feel anxious and moody and irregular. That's because there's immaturity of the ovarian hormone production. Immaturity then in the teenage years, and then on the other end of the spectrum, there's like your erratic and kind of a chaotic nature to that estrogen. And that is why sometimes menopausal hormone therapy is helpful, especially if the levels are lower. So we give a steady low kind of buffer zone of estrogen so that your estrogen is never bottoming out. and we give you a nightly dose, or we cycle progesterone because you're not always ovulating making progesterone. But for some women, they do better actually on a birth control pill because it takes this chaos, this
Right.
irregular unpredictability, which often can be the first sign where people are really anxious and really irritable. And sometimes women are off put when we tell them a birth control pill could be a good option for you. They're like, oh, you're just trying to put me on the pill and just dismiss me. No, 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 no.
Yeah.
Yes, some doctors do that because it's just like their knee jerk reaction. But actually, the doctors are doing it for good reason. They just don't maybe explain it to the patients. What we're trying to do is temporarily stop this chaos. So instead of your ovaries doing that crazy production, the birth control pill is quieting the ovaries down, saying, like, girl, I got this.
Yeah.
I'm going to deliver you this steady dose. And that can be really helpful, can be used with vaginal estrogen if you have vaginal dryness, and is not the cure all for everybody. Some women don't do well on a birth control pill, mainly because they probably are sensitive. They don't tolerate the synthetic progestin or the synthetic estrogen as well as they might menopausal hormone therapy. But if your symptoms are being driven by the unpredictability and the volatility of your estrogen and progesterone production, sometimes those women do better on the birth control pill. But it's not a one size fits all. So I always tell women we can start with one, but be open minded for the other in the perimenopause. And then the one last thing is for women who are really don't want a birth control pill, but they have irregular bleeding and they need contraceptives. Sometimes we give them both. We give them a progestin only birth control pill, helps with bleeding, gives them pregnancy protection, and then we give them a transdermal spray or patch to help with their estrogen. So we've got a lot of ways we can help you.
Yeah, I thank you for laying that all out. And I just want to share again anecdotally, and I hope people don't mind. I share about myself. I don't do it just to talk about myself. I really do it again to just
Yeah.
encourage you to sort of recognize what's available to you now. And this platform, these conversations that are happening all the time are so helpful because they aren't the conversations that were necessarily happening, certainly not in public 5 years ago, right? But I walked into my gynecologist's office with anxiety, horrible anxiety, and she took her time with me and sort of, helped me lay out or express to her
Mhm.
all of what was going on. And she said, "You're in perimenopause. You can just be on the pill, and just kind of write it out." And I was so resistant. I was that patient who was like, I think I'm sick of hormones. And she said, "Well, you're 43. We can talk about MHT or HRT as we were calling it back then." And I was like, no, because the conversation then wasn't as exposed and sort of
Yes.
the clarity was not highlighted and amplified like it is now. So these conversations can't happen enough. I want to address something that came in. The medication, the drug that Dr. Menn was referencing is called Duavie,
Mhm.
Duavee.
Yes.
So
Yeah.
to that person, and itchiness down there, somebody asked about. What is happening? What can help? Are there conditions sort of beyond the changing pH of our vaginas in perimenopause and into
Yeah.
menopause that we should be aware of?
Couple of things. So itchiness can come from obviously dryness, lack of lubrication, thinning, loss of collagen in the vulva and the vagina, the change in the pH, the change in the microbiome can also set off that you are more predisposed to getting a yeast infection or bacterial vaginosis. And I see women get ping ponged with those diagnoses back and forth. They're treated with an antibiotic. The next thing they know, they get a yeast infection. So it's never really too early to start vaginal estrogen in the perimenopause. If you've got symptoms, go for it,
Mhm.
and it can make a huge difference. But we don't want to miss things. There is something called lichen sclerosis that is incredibly underdiagnosed. It's a
Yeah.
progressive skin change that causes very persistent itching, thinness, and paleness of the tissue, particularly around the vulva. And it really needs to be diagnosed on exam. So when I have a patient who presents with what appears to be a classic GSM, genital urinary syndrome menopause, we offer them vaginal estrogen. We make sure they're applying it correctly. Remember, vaginal estrogen cream can be applied up inside the vagina, which is great because it gets up into the bladder that way through being absorbed through the wall there. but also you can apply it externally on the vulva and the labia. So sometimes I see women who are given an insert twice a week and it helps, but it never really gets to the outside. But if you are doing that and you still have persistent itching, you really need a good vulvar exam to make sure you don't have lichen sclerosis, which
Right.
the incidence of diagnosis pops up around this age group. So you could have two things at once. And
Yeah.
vaginal estrogen is not contraindicated with lichen sclerosis, but vaginal estrogen is not the treatment of choice for lichen sclerosis. You need a high potency prescription strength steroid cream for that. So yeah, that's
Awesome.
one tip there.
Thank you so much. Um, just shifting gears and sort of getting back to those sort of lesser known symptoms of perimenopause. Someone asked, why do I suddenly smell different? My body odor is stronger and has changed.
Yeah, so our sweat glands are really sensitive to changes of estrogen, testosterone, and progesterone. For some women, when the estrogen levels go really low, now testosterone is more prominent in relation in terms of what your skin cells and glands are, being stimulated by. So you could have more oily skin, you could sweat more, the odor changes. Hormone levels affect pH of the skin and odor. So that is not an unusual symptom, right?
Yeah.
So yeah.
Okay, I just have to add, I had that one too. I feel like being in this line of work, I was like plowed with every symptom just so I could talk about it.
Yeah.
But like dry mouth,
Hmm.
so bad breath,
Yep.
and like body odor was a thing, and it would happen to me mainly when I was sleeping and night sweating, and I felt like I smelled like the inside of a deli. Like I smelled like it was so revolting, but that's what it was. And when I started MHT, it actually resolved.
Yeah.
Somebody asked, speak to that, to resolutions or not. If things are resolved for the most part, but there's like an outlier, the person's comment was sleep. She's still having trouble with sleep.
Yeah.
What can we do? What are some solutions
Well, a
available?
couple of things. One, make sure that talk to your doctor. Maybe your dose needs to be changed. Maybe you need more progesterone. Maybe you need to change your estrogen. And not all sleep disorders are menopause related, although we know sleep is a huge problem. Obstructive sleep apnea. I've
Mm,
just learned the numbers on this from my friend, Dr. Andrea Matsumoro, who is amazing. She's a sleep medicine specialist, so go check her out. But she informed me that over 60% of women in the perimenopause menopause time have some form of obstructive sleep apnea. I have
amazing.
a good friend who doesn't have very, very bad, she doesn't have bad menopause symptoms. She's not complaining of hot flashes or night sweats. But recently she's had worsened sleep issues and she just found out she is not breathing
Ugh.
70 times every hour. Okay. And she wasn't even a
Wow.
heavy snorer. So I strongly recommend if you are on MHT, you think your hot flashes and night sweats are well treated, just speak to your doctor about being referred for a sleep study. You can even have them done at home. Sometimes they do them in the hospital. There's different ways depending on your needs, but I think a sleep study is well worth doing. I also think remembering that a lot of us have very bad sleep habits that are we're not helping ourselves with: screen time, alcohol use, caffeine use, exercise, lack of exercise, addressing anxiety, social stresses, relationship stresses. So there's a lot of factors to go involved with sleep. So really you need to think deeply about it. Cognitive behavioral therapy for insomnia. It sounds complicated. It's really not. There's a bunch of great online tools that are free, and apps you can download. I highly recommend that. So yeah, those are my big, sleep habits, CBT for insomnia, adjust your hormone therapy doses if needed, and speak to a sleep specialist.
Awesome.
Yeah.
Um, Sorry, we're getting close to the end of the hour. Thank you so much for this time, Dr.
Mhm.
Menn. I'm taking advantage of your last 10 minutes.
Yeah, yeah.
Overlap with other conditions. So this question was, my energy is gone and I'm always cold. How do I know if that's perimenopause or thyroid? You spoke about thyroid early on
Yeah.
in this hour. What should we be getting tested for and how do we determine what to push for?
Well, so in the perimenopause, again, not everything is perimenopause, and two things can exist at once, right? So new onset of thyroid disorder or your thyroid not being under control, please see a board certified endocrinologist who knows how to manage thyroid disorder. There's a lot of thyroid coaches out there these days with promises to supplements and really extensive lab testing that goes beyond the pale. So make sure your thyroid is, your TSH, your free T4. Sometimes there's extended panels that need to be done, but it's best left to a board certified endocrinologist, in my opinion, on managing that. But definitely something, particularly if you're having new onset of temperature changes, new onset of anxiety, heart palpitations, weight changes, energy changes, something to be investigated. Many, many women, and this may not be this person, but it's important for women to be aware. Perimenopausal women are at very high risk for iron deficiency anemia, low ferritin levels because of irregular bleeding, right? Heavy periods, irregular periods. So please check for anemia, ask for a ferritin level. It is really, there's like an epidemic of iron deficiency anemia out there. So that's another thing that can cause a lot of these symptoms, right? So that's another thing I would get checked out. And then certainly those temperature fluctuations, the classic symptoms of the perimenopause is it's deep within your hypothalamus. There are neurotransmitters there and areas of your brain that control our temperature. And when our hormones are wackadoo, that's what happens. And
Yeah.
that's where,
Um,
yeah.
Dr. Men, I won't ask the next two specific questions because I think you said this several times and it's threaded into this hour is two things can be true at once. So you can have an autoimmune condition and perimenopausal symptoms. You can be having heart palpitations and anxiety. You spoke to this earlier in the hour, certainly go for a workup if that's something, certainly if it's time as well. I think 50 is like a time for a cardiac assessment. Um, this is just, I want to, somebody asked that, um, sorry, I lost the question. I'm gonna find it. And it kind of brings us back to the reason we're having this conversation. So as much as we think it's clear, I want to give you a chance to answer. This person says, the woman I love needs help. Her symptoms are all over the place. What can she do? It's such a baseline start, but
It is.
where do
What
we
can you
start?
do if your loved one is recognizing this? The best thing you can do is meet with a menopause specialist who's practicing evidence-based medicine. Give them your full medical history, your menstrual history, your family history, a full symptom inventory. Okay. You're not crazy. It's not all in your head. If you have to ask that question or pose that question about a loved one, that person needs
Yeah.
medical help. We would not ignore any other thing in medicine. We don't wait when you have eyesight problems. If you break a hip, we bring you to the OR. If you have cholesterol changes, people are very quick to throw you on medications, rightfully so in many cases. I'm not saying that's bad,
Sure.
but I'm saying we don't ignore it and say, just stick it out. You don't have to feel bad at this time. And if you're afraid about hormones, it's okay to at least consult with somebody and know what your options are, what the
Yes.
benefits, risks, are and what other things you can do. Because at Alloy, like for instance, like there are many women who come to us and we might prescribe hormone therapy for them, but we're also going to remind them constantly, whether it be support groups or educational content, webinars, etc., that a patch is not going to fix your crappy lifestyle, your
Right.
crappy nutrition, your sedentary life. Go back and listen to. I encourage everybody listen to Dr. Klingman, Shannon Klingman, who's an incredible woman who was the founder of Lumi deodorant, which is a great deodorant, by the
Yes.
way,
Yep. You
if you
just
need help.
posted about her.
And
Yeah.
I just reshared a video, and she's
Yeah.
someone who was living her best life on HRT, and now she has a breast cancer diagnosis, not from the HRT.
Right.
She, and she, and she is dealing now with breast cancer treatment, and she has decided that because she can no longer use her hormone therapy, she must do the other things in her life. And what she said very boldly was that honestly, she loved HRT. She wished she could still use it, but she feels better than she ever has in her
Yeah.
entire life because she has a newfound reason why she must pull all the other levers, which I love that language, all the other levers of health, which are the pillars of lifestyle medicine. And you can live really, really well without hormone therapy, but hormone therapy can be a really incredible tool, but it's not the only one.
I love that so much. And
I
thank you
loved it.
for,
Her reel was amazing. I had to reshare. The other thing
I saw.
The one other thing I just want to get in is this
Yes.
birth control pill thing, because we're talking about perimenopause. So many people are afraid of the birth control pill. I just want to remind people the birth control pill lowers your risk of ovarian cancer by 40%. It lowers the risk of iron deficiency anemia. It greatly can control painful periods, endometriosis, premenstrual dysphoric disorder. It can be an incredible tool. Women have less breast cysts on the birth control pill. There are lots of reasons why the birth control pill can benefit us in many ways. I am not saying it's the only tool out there, but in the perimenopause, just be open minded about its options and we can be aware of its limitations. I want to also acknowledge people will often tell me they were doing great on the birth control pill and now they're whatever age, closer to full menopause, and it's just not cutting it. And they say, I
Right.
don't understand why. My doctor tells me the birth control pill has high levels of estrogen in it. This cannot possibly be from menopause. I'm here to tell you, you could be on the birth control pill and suddenly it's not working for you. You have hot flash, you have night sweats, you don't feel good, your joints ache, you're moody, something's different, something's changed. Birth control pills are not estradiol. They're ethinyl estradiol. They're high dose, high potency. They can change the receptors, and at some point, there can be things, mechanisms of why they are no longer cutting it. Or some women will just frankly do better on an FDA approved estradiol, right? And the progestin is not progesterone, it's a synthetic progestin. Some women don't react well to that, or it doesn't cut it after a period of time. So it helps some people, doesn't help some people. So just be open minded.
Thank you for that clarity and
Oh,
honesty.
it's the
It's
most
so,
common thing
so
we hear about. Yeah.
important. Yeah, oh, I'm sure.
Yeah.
Um, Finally, Dr. Menn, is there anyone whose perimenopause stories you think are sort of remain invisible?
Yes. Many.
Yeah.
Yes. So I think Black women in particular, and women, who have just historically been dismissed, and that their level of suffering is for some reason is like there's a higher threshold for us to help them, and also a lot of shame in talking about these situations, and the fact that these women can have their perimenopause and menopausal symptoms happen earlier than their white female counterparts. So that's just something to keep in mind. The initiation of these symptoms can be younger. Black women also are much more likely to undergo a hysterectomy and remove their uterus but keep their ovaries. What happens when you remove your uterus and keep your ovaries? Your menopause can happen 2 to 3 years earlier than it would have in terms of the ovarian function. So if you're a Black woman who's more likely to have fibroids or adenomyosis, more likely to lose your uterus, and more likely to have earlier menopause to begin with, and then we take out your uterus, but keep your ovaries, and we don't explain that these symptoms can be popping up. It's a huge problem out there. So I think that's certainly a population of women where it is under recognized, right? The other group is women who have some complicated medical condition. I just looked this up today. 80% of women by the age of 50, so certainly plenty in their 40s too, but by age 50, 80% of women will have some chronic medical condition, being diabetes, hypertension, and autoimmune disease, arthritis. So those women in perimenopause, because they have like a red X on their face or on their back that, oh, you've got a medical problem, I
Right.
can't treat you with hormones. Those women also are really left to suffer in perimenopause because they're labeled as complicated. And so doctors who already don't understand menopause or
Yes.
perimenopause, the minute you walk into the room with anything, like I like to say, you're a weird Barbie, you're not like the stereotypical perfect candidate for hormone therapy, those women are often dismissed too. So those are two big batches of women. This is why we're trying to reach younger ladies before they even get there so that they can speak up so that when they have these things, they don't have to wait 5 to 10 years to freaking get the help they need.
Ah,
I'm
you are
sick of it.
so
I'm
you are
sick of
so
it.
sick of it, and your passion is contagious. You are so on fire, Dr. Men. I never, ever, ever get sick
It's just
of
the coffee.
speaking
It's
with you.
just the
It's not
coffee.
the coffee. It's not the coffee. You bring so much information, clarity, wisdom to us all. Um, I want to thank you, Dr. Mann.
Yeah.
Thank you so much to the women, partners, men. I don't know who's all joined us today,
You
but
know, I
thank you
think
for
there were
being
some
here.
men. That's really
And me,
cool.
it is really cool.
That's sexy. I like that.
It is sexy. I will be I will be speaking with Dr. Mann, as I mentioned again soon, for what is sure to be a fantastic webinar we've never done here at Alloy about breast health and hormone care. people wrote such really nice things about you,
Oh,
Dr.
good.
Menn, here in this thread. So thank you so much. And keep coming, keep
Yeah.
asking questions. Always DM me. I'm like giving my email out now for people who want to have questions about alloy. Here it's Rachel, Rachel at myalloy.com. Always reach out. I'm community manager. I'm here for you.
And a
So
reminder that if you come to Alloy for your menopause care, your weight care, skin care, sexual health care, then once you're a patient with us, not only do you get to message your doctor whenever you need to, it's like having a specialist in your pocket, but Rachel, along with many of our doctors and other guests will, run these amazing support groups. So it's like you get like private, like one-on-one time
yeah,
like this, but
thank you.
within a private webinar where you get to spend time with Rachel, who just brings so much honesty and light and education and really helps facilitates these conversations. So it's a very special added thing that you generally you don't get that from your regular interaction with your medical doctor. So
Thanks, Dr. Menn.
yay.
Bye, everybody. Have a
Bye guys.
great rest of the
Happy
week.
perimenopause day.
Happy Perimenopause Day, everybody. Thank you. Bye
Bye.
bye.